Chapter 18, Research and Development in Population Health. Measurements are essential to track the health of people, work sites, and communities. Research and development in population health is a challenging but potentially rewarding experience. Fortunately, those that enter the field today can learn from the early efforts of population health pioneers. Seminal work by D. Eddington and John Wenberg have provided an understanding of the natural trend toward illness over time and the impact of variations in care. Much work remains to be done before standardized, effective programs and initiatives make significant progress in achieving the triple aim of healthcare, which again is improving health, improving experience of care, and reducing cost. The vision of population health is healthy people, healthy work sites, and healthy communities. If the health status of a population is to be improved, then objectives for health and measurements of progress toward these objectives must be identified. Now, measures of progress toward improvements in population health should include clinical indicators, including processes and outcome measures, assessment of patients and provider satisfaction with healthcare, functional status and quality of life, economic and healthcare utilization indicators, as well as impact on known population health disparities. Now, research can be described as any systematic investigation to establish facts. Research is carried out to increase the understanding of fundamental drivers and responses to drivers of behavior. For example, cause and effect. Now, in population health, research is usually focused on understanding how different actions affect behavior change, how these changes influence population health and wellness. We have two basic kinds of research. You have primary research and secondary research. So for primary research, it involves the collection and analysis of original source data, which is collected specifically for the research study. And then for secondary research, which involves the analysis of existing data and prior research information for possible new uses or conclusions. Now, the scientific method provides a framework for conducting research. The steps of the scientific method are identifying a topic, generating a hypothesis, defining a data collection and an analysis strategy, gathering data, testing the hypothesis, and then also making decisions based on the results. Now, whether applied to primary or secondary research, the scientific method provides structure for a research project. Now, due to the upward trend of healthcare costs in the U.S. challenging the competitive nature of business, establishing evidence-based solutions that improve the effectiveness and efficiency of care delivery will help advance healthcare delivery for everyone. Now, for population health research, studies typically utilize one of the four research designs: a double-blind confirmation, trend analysis, comparative effectiveness, and predictive modeling. Double-blind confirmation is the ideal research approach to establishing a causal link between intervention and outcome based on severity-matched double-blind study double-blind study methodology. Now, cohort are matched by their relative level of illness and separated into experimental and control groups. The experimental group is provided a new treatment or service, while the controlled group receives usual care. And then the cohort-matched, double-blind experiment and control studies are hallmarks of population health. However, these studies are expensive and often impractical. Trend analysis is a study design that is more common, less expensive, and often a more practical approach. Now, since this is not a double-blind study, illness burden match design, researchers are less able to establish causality. Now, trend analysis also allows study of the same population cohort over the course of new treatment or service to determine its effect. This method compares a population cohort at two different points in time, generally before and after intervention, and then also to the regression to the mean. Now, when using this method, a researcher must take into consideration the population of patients who are dealing with significant illness will improve over time even without the treatment. Now, this is a challenge for researchers to prove that the intervention produces a greater effect than the normal healing process. Comparative effectiveness compares two or more different treatment approaches. Now, in population health contexts, this is usually found out by comparing the effect of a program or therapy on a group of participants with a severity-adjusted cohort of participations in a different program or treatment pathway. Then you have the severity adjustment. Now, an adjustment process to control for confusion in case mix, etiology, and severity among hospital patient populations. Low values occur in groups that are not very ill. High values are seen in groups that are very ill. This is required in smaller comparative studies because of the burden of illness may be significantly different between groups, thus influencing the outcome. As the size of the comparative group increases, severity adjustment decreases. And then you have selection bias. Now, the bias introduced by the selection of individuals, groups, or data for analysis in such a way that proper randomization is not achieved, thereby ensuring that the sample obtained is not representative of the population intended to be analyzed. So to avoid this bias, comparisons must be made between two local organizations, one where new intervention is piloted and the other where the traditional approach is taken. So in other words, you want to conduct a double-blind study. Predictive modeling is an approach that uses existing data to predict future behavior or consequences. Now this is illustrated by asking three primary questions. How are we doing? How can we make this better? And what if we did this? The what if question can help formulate and pretest hypotheses about improvement. And also findings for such modeling exercises allow researchers to anticipate consequences of an intervention on a population. And then the last bullet for predictive modeling is altering the trend predicted is an important goal of population health research and development. So research development processes. Development can be described as a systematic process to transform research into action. So you have two primary categories of development processes. You have the new concept development as well as systematic process optimization, or SPO. Now, for the new concept development, it's often applied to the exploration and development of a new product or services. Now, this consists of 5 primary steps, or the SDAM process. You have search for unmet need, explore the alternative best solutions to the unmet need, develop the best solution, apply and assess the developed solution in the market, and then maximize the effect and penetration of this new product or service in the marketplace. So again, the 5 primary steps of the SDAM process, you have search, explore, develop, apply, and maximize. And then for the systemic process optimization, now this reduces the number of defects in an existing process. It utilizes statistical measurement of current processes or procedures. This also looks for opportunities to improve them with the current program. Simultaneously, improvement of both effectiveness and efficiency, such as like for Six Sigma, Lean, TPS, and then also successfully applied to the healthcare. Development process programs have also demonstrated the power of creating common frameworks for continuous improvement that translate into 3 keys to success for effective population health development. First, you have the issue ownership by all core constituents. Now here, research must be compelling and accessible and made relevant to each participant in order to develop true ownership and collaboration. And then you've got champions for change. Now by key respected and trusted figures in the specific population as well as the population at large. So what gets measured gets done or improved. Research efforts must be made clear, compelling, accessible, and relevant to each key champion. And then you've got the convergence of constituencies. Now here it's aligned measurement approaches are key to deriving convergent behaviors by each. How each constituent defines success determines what will be measured and how success is determined. Systematic measurement of improvement in the health status of population is a key component of research and development. Now, proof of concept refers to the demonstrating the impact of a program or product using measures of effectiveness, efficiency, or both. Best way to establish proof of concept in the real world is to conduct a well-designed pilot. Now, efficiency studies are increasingly in demand as global healthcare inflation continues to outpace general inflation. These types of efficiency studies have often analyzed utilization data such as health and disability claims, laboratory data, as well as pharmacy information. Effectiveness studies seek to determine better ways to improve care outcomes. So they're going to rely on aggregation of data extracted from medical records. This can include lab and/or pharmacy data. And then one could argue that there is a sensitive balance between efficiency and effectiveness. Ideally, they should be aligned. Maximizing efficiency would be associated with greater effectiveness. However, systems that attempt to do too much will fail to produce the desired results. So in other words, you're going to see too many patients per hour. So you want to increase the number of patients you see, but you're going to see too many and you're going to decrease the quality of care. Assessment of the value of population health efforts include return of investment studies, as well as capture of less tangible impacts. Increasingly, the broad evaluation of population health programs includes the satisfaction of key constituents, patients, caregivers, providers, and purchasers. Now, measuring perceived value from multiple perspectives is crucial to the development of lasting, successful programs. So here are some emerging transformational research technologies. You've got personnel monitoring, diagnosis, and communication. So mobile communication devices or biometrics. So since mobile devices are getting smarter, many are experimenting with collecting biometric and clinical data directly from the patients or subscribers in real time for electronic integration into the EHRs or electronic health records. Now this can include blood pressures, steps taken, your sleep, your caloric output. And then also you've got biological markers such as genomics, proteomics, and then microbiomes. Now the study of these new fields help to develop correlation to health and disease. Each will have significant effect on population health research. Expanding knowledge will likely require a reassessment of disease and its classification, which will cast a new light on treatments and cures as well. And then you've got big data. Then you've got tracking for comparative effectiveness. These technologies enable researchers to manage large volumes and varieties of data in more accessible, affordable, and usable databases for significant mining and correlations. So for an example, a double-blind comparative effectiveness studies now can be generated faster and less expensively. The key constituents of healthcare delivery are patients, providers, payers, purchasers, and suppliers. For patients, this would be ease of access to programs and services that can produce tangible benefits with minimal inconvenience and expense, which would be the greatest of interest. For providers, providers are mostly concerned with applying evidence-based guidelines and producing clinical outcome improvements. The payers pursue studies utilizing claim data to demonstrate efficiency gains. And then the purchasers, which are especially employers, demand evidence of improved functional status and reduced absenteeism and disability. And then, of course, the suppliers, which will be your pharmaceutical and durable medical equipment industries. They're going to apply population health research to demonstrate the value of their drugs and devices by showing decreased medical utilization and costs. Now, a way to categorize measure is based on the work of Donna Bedian, who described a framework of structure, process, and outcomes. Now, without much difficulty, one can tie structural and process components to better results. Structural and process indicators of improved outcomes are easier to measure than are patient outcomes. So generally speaking, research and development in population health draws from a measurement toolkit. Surveys and health assessments are often the first tools used to measure baselines, process measures, and health outcomes in population health. One of the easiest tools to deploy is a satisfaction survey. The future may rely increasingly on personal health records, or PHRs, which may be tied electronically to the electronic health records, or EHRs. Surveys requesting patients' evaluations of care providers are also being utilized. Providers are also being asked to evaluate their patients' compliance with and adherence to treatment plans. When focusing on efficiency studies, the use of claims data is foundational. Health plan claims data can also demonstrate the use of recommended services by a population, such as screenings and preventative services, or such analyses may reveal overuse of questionable treatments. Pharmacy benefit management organizations can use their claim information to eliminate the impact of medication use and adherence as well. We also have the ICD-10. Now, this improves specificity of analyses and increases complexity. So the ICD-10 codes exceed over 171,000. Now, when we had ICD-9 about a year ago, there were about 17,849 codes. So you can see it's definitely increasing complexity, but it is definitely improving specificity because of the increase in number of codes. Medical records, which are a rich source of data that can be used to assess the need of new population-based programs and services. So EMRs, or electronic medical records, and personnel health records offer the promise of more real-time data. Tangible clinical results of population-based research and development can be obtained through health risks appraisals and biometrics such as urine and blood tests. Now, these results can demonstrate wellness or indicate control of a chronic illness. Disability reports track the incidence, cause, and costs of short and long-term cases. Now, this can give employers a measure of the most compromised cohort of their employee population. Employee population is particularly attractive because of the potential for significant improvement in functional status and return to work. Other factors that influence disability are job satisfaction and recent job performance. Challenges to successful research. Bias is a form of systematic error in research and presents a formidable challenge. So here are some concerns. Selection bias in participation cohorts, clinical and administrative bias by those who provide the intervention, even publication bias, since journals are much more eager to accept manuscripts than demonstrate effectiveness. And then, as discussed previously, double-blind cohort-matched experimental models offer the best defense against much of this bias. Time can also be a significant challenge to effective research. Many programs have claimed success in changing people's behavior. The true success, long-term maintenance of this change, and then some disease states complications also require years to develop. And then confounding influences are difficult to eliminate in population health studies. Programs are affected by individuals, community or residents, media influences, healthcare professionals providing treatment, economic status, gender, language, and cultural beliefs. And a greater sample size in both the experimental and control group may allow researchers to measure and statistically control for this effect. Using severity adjustment techniques and tracking experimental and control groups over time are the best ways to deal with unrecognized or uneven illness severity and regression to the mean. So establishing goals can best be accomplished by establishing baseline measures and determining what may be possible to change under ideal circumstances. Also, engaged in a crosswalk from the baseline to the predetermined stretch or ideal goals. Pilot programs can test whether the intervention steps were successful in achieving the goals. Goals can be based on governmental or national respected efforts. Establishing quantitative benchmarks is an effective approach to goal setting. Benchmarks are derived from three primary sources: history, by measuring participants' personal best; aspirational, what program designers hope to accomplish; and then assigned according to the established goal or another cohort, example, a control or best practice. Now we're going to discuss the 5 segments of population health status. You have the well, at-risk population, acute illness, chronically ill, and catastrophic illness. Let's look at the well population. So they are increasingly holistic. Now this encompasses many different domains. You've got physical wellness, emotional wellness, spiritual wellness, intellectual wellness, environmental wellness, as well as social wellness. When talking about the at-risk population, risk mitigation can markedly improve the long-term health status of populations. To accomplish risk reduction, great effort has been given to development and refinement of health risk appraisals and biometric screening. And the mitigation of health risks can result in lower healthcare costs and improved functionality. Acute illness is usually defined as sickness that is short-lived and typically resolves without complications such as sore throat, flu, low back pain. Less attention is given to this population, but can have a significant effect on the health of a population, such as the pandemic flu. So for the chronically ill, efforts to reduce the illness burden of the chronically ill segment have been characterized as disease management. Diabetes, coronary artery disease, asthma, emphysema, congestive heart failure, depression. These are typical type of diagnosis for the chronically ill. Many are enrolled in disease management programs, or the many that are enrolled in disease management programs live with multiple diseases and conditions. The catastrophic ill are the most fragile cohort. They are the end-stage cancer patients, the stroke and/or trauma victim patients. They normally comprise only 1 to 2% of a population of covered lives. So from an economic standpoint, health plans, insurers, and employers have often defined these population segments by the economic costs associated with their care. Those whose health care costs mainly exceed $50,000 in a year are going to be termed a catastrophic ill. In conclusion, well-respected research approaches such as double-blind or comparative effectiveness methods can produce proof of concept results. Understanding biases and trends of illnesses within a population can reduce the misinterpretation of outcomes. Sophisticated biometric analysis can both compare the past to the present, and validate improvement in future performance against that which was predicted. Such techniques can shorten the window of time required to reach statistical significance and move a project forward. Pilot efforts can bridge research and development. Those that demonstrate improvement in the effectiveness or efficiency of existing or new population health products or services are worthy of further development and, in some cases, large-scale application in the marketplace. And then when designing and producing new products and services, great care must be taken throughout the process to appreciate the viewpoint of all constituents. So this concludes Chapter 18. If you have any questions, please let me know. Thank you.